So thank you everyone for coming today. The topic that I chose was cancer and pregnancy. And this is just a general topic. It's not specific to any particular case. So when I was doing the research for it, the question that kept coming up for me is when is midwifery care an option if someone presents with cancer in pregnancy? So I'll start with some background information, and then hopefully at the end we can do a little more of an open discussion as well. So can everyone hear me okay, clearly? Okay, perfect. Thank you. All right, so some background information here. About 1 in 1,000 to 1 in 1,500 pregnancies are complicated by some form of cancer. And those statistics include up to 1 year postpartum. And the reason why that is because the diagnosis of breast cancer is often delayed because of the physiological changes to the breast tissue during pregnancy. So that incident is expected to increase as women are delaying pregnancy, basically just getting older and, kind of settling their lives before starting a family. Breast cancer is the second most common cancer in pregnancy. Cervical cancer is the third most frequent, and it's actually the most frequently diagnosed cancer, and probably because in the medical model, a lot of times they require a pap smear on the onset of care. Thyroid and ovarian cancer are rare, but it did show up in a couple of studies that I read. Lymphoma and Hodgkin's disease is the fourth most common, and the most common is melanoma, and that's complicated. It complicates 11.8% of the cancers in pregnancy. One of the statistics that is actually not on this slide, but in the one I sent out today, is that almost 80% of women that choose to treat with allopathic treatments survive, opposed to about 45% of women who decide not to treat will survive cancer during pregnancy. So what are the factors that impact the development of cancer in pregnancy? These are divided into two categories. The first one are all those changes that support a healthy pregnancy and support normal fetal growth, such as the hormonal changes, metabolic changes, hemodynamic changes, immunology, and the increased vascularity. Those also make a really fertile ground for cancer to grow and spread. The other factors are not specific to pregnancy. These are just general. So if someone is using alcohol or drugs, they would be more likely to get diagnosed with cancer. A family history, especially of ovarian cancer. And for cervical cancer, lifestyle choices such as multiple male sexual partners. A high BMI and dietary choices. There's also environmental exposures. I did read one study that followed women after Hiroshima, but it doesn't have to be as significant as a nuclear fallout. It can be other toxins in the environment or other environmental exposures. And again, they increase maternal age. So there's a few considerations when people are trying to decide about treatments. One is whether or not you are going to get treated or take an allopathic treatment, and then what is that treatment going to be, and then when will you decide to treat. So I'll talk about the treatments in a couple of the slides coming up, but this particular slide is about the when. So most of the allopathic treatments are contraindicated during the first trimester. This is when the basic structures of fetal development are occurring, and that's the incident of where you can get congenital anomalies, mental retardation, and also a very high risk of fetal loss during this time. The second trimester is considered safe for many of the allopathic treatments, and the third trimester is also considered safe, but oftentimes in a couple of the studies I read that women were either waiting until after the baby was born or inducing and then starting treatment, because some of the treatments actually cause preterm labor. So rather than expose the fetus to some of the chemicals, they were choosing or opting to wait. So some of the treatment options that are available. So the first thing I want to mention is in multiple of the studies that I read, they really highlighted that, you really need a multidisciplinary team. You need an OB, you need an oncologist, a radiologist, you even need a psychologist, but there was actually no mention of a midwife on any of those studies. And to me, that was a little bit unusual, because at 2 of the clinical practices that I've been at, there have been at least 3 cases of women either having active untreated cancer, having cancer, been treated and gotten pregnant, or undergoing diagnostic testing, and clearly a midwife was part of those team. So I just kind of wanted to mention that. The next thing I want to mention is in some of the older studies, therapeutic abortion was considered necessary before starting treatment. That is no longer promoted. Pregnancy is not considered a risk factor to the success of treatment. So here again, they're talking about allopathic treatments and not necessarily the growth of cancer. So most of the studies really focused a lot on the treatments and not necessarily, cancer itself. One of the most, one of the treatment options, which is considered the safest, is surgery for solid tumors like a breast lump or other places in the body. So the surgery itself is considered safe. However, in the first trimester, spontaneous fetal loss does increase, and this is considered because of the anesthetics that are used. It also increases preterm labor, and that is thought to be because of maternal pain. So pain management should be included in the plan. Another option for treatment is sentinel lymph node biopsy. So if there is a solid tumor, it's going to drain lymphatic fluid to the closest lymph node. And so they would biopsy that because that's the place where it most likely will metastasize to. And it is now considered safe during pregnancy. And some of the earlier studies I read, it was saying that it was not safe, and not so much, again, because of the surgery, but because of the dyes and the chemicals and medications that were used. But now with changes and progress, it is now considered safe. The next 2 treatments are probably ones that we've at least heard about, is chemotherapy and radiation. And chemotherapy is a systemic treatment, so the goal is to prevent cancer from spreading to other parts of the body. Again, it is considered or contraindicated during the first trimester because of the low molecular weight. It crosses the placenta and can cause birth defects to the fetus. It also compromises the immune system. So the opportunity for other infections like CMV are also increased. Breastfeeding is also contraindicated during this time because the chemicals and the medications excrete into the breast milk. If a woman wants to breastfeed, she would have to wait until 2 weeks after her last chemotherapy session. And during that time, she would have to pump and dump. Also, if treatment is started during the 3rd trimester, spontaneous labor or preterm labor is also increases, and that's why in some of the studies I read, women were choosing to wait until after the baby was born rather than expose the baby to the chemicals. The next one is radiation, and that's more localized treatment. This one, most of the studies said is contraindicated in all trimesters. This one in particular is where some of the really nasty defects, mental retardation, and some other really kind of heartbreaking impact to the fetus can occur. A number of studies now are saying that if it's necessary during the second and third trimester, radiation can be used in very low doses, and there's a variety of different types of radiation that can be used. And again, the woman would have to work with her oncologist as to, what doses were appropriate. There's also a number of complementary treatments, and they're divided into two categories. One is more for comfort, for pain management, dealing with the side effects of the treatment, such as nausea and vomiting, dry mouth, hot flashes, fatigue, anxiety, and depression. Acupuncture came up a lot in those lists for that. And then the next one are true alternative therapies. So the goal here was, one was to stimulate the immune system, and then to work against the tumor, anti-carcinogenic, and also treat symptoms such as nausea and vomiting. So I've included some herbal treatments here that were listed in one of the studies, which is in the reference section. One thing I don't have on here is also the traditional Chinese medicine, and that would also probably fall under this herbal protocols. I found one paper out of an institute in India, which is called the Midwifery protocol, and there were a number of different homeopathics that could be used, and they were dependent on the type of cancer and also the constitution of the person. So the woman would have to work with someone that specializes in homeopathy to be able to, one, tailor it for the type of cancer, the protocol, and also her constitution. I read a lot of anecdotal reports about raw vegan diets, but more specifically raw diets. I was not able to find any actual studies on it, but again, there were still a lot of anecdotal reports about it. Does anybody have any questions so far on any of that? Okay, so when I was going through this, especially because of the two of the practices that I've been at, had women with cancer as part of their practices, is I started thinking about, okay, what would I take a client into care that has cancer, and kind of what are some of the questions that I would ask myself. Kind of what are those factors that would risk a client out of care, and is it really the cancer that risk a client out of care, or the side effects of the treatment? So I've got a list of questions here, and I'll just run through those, and then hopefully if anybody has experience with cancer with pregnancy or had clients, or maybe want to add anything, I'd love to hear other people's experience. So the first question that I would ask, which I haven't actually listed on here, but I probably would ask why the client is seeking out midwifery care, just like I would in a normal client, just to kind of see, what her state of mind is at and kind of what she's thinking. So just trying to connect with her a little bit as to, her reasons for seeking out a midwife to be part of her team. And as I mentioned on a prior slide, the standard of care is a multidisciplinary team. So just kind of, that's kind of how I come up with these questions with that in mind. The next thing I would ask is, the diagnosis. What type of cancer does she have? If she has cervical cancer, a C-section might be her only option based on the friability of the cervix. So I'd want to know that. I also want to know what stage of cancer she's at. You know, labor is pretty hard work, and if someone's in a like an advanced stage, you know, are they going to have the energy and the to make it through labor and a natural childbirth? So that would be something also I would think about asking. I also want to know if they are taking treatment options, and if they are, what is that treatment option, and also how are they responding to that treatment. Some of the other things I'd also probably be looking for if I decided to keep a client in care is if, for example, they are taking chemotherapy, or even if they're not, I'd be probably looking for things like preterm labor, checking growth of baby. Low birth weight is something that's common with women who are on chemotherapy. Prematurity, oligo, so low fluid levels, and also stillbirth. The chance of stillbirth goes up with chemotherapy, and also IUGR. The next thing I'd probably look at is, are there any kind of diagnostic tests that either I would require them to have, whether or not they're in treatment or not. Maybe during first trimester, I may ask for HCG levels. I want to know if her body is able to maintain a healthy pregnancy, and if there's you know, any support that needs to be done there. One of the things that happened, especially with chemotherapy, is low white blood count, low red blood count, and also low platelets. So I might want to have a CBC done more frequently. The one thing I didn't mention on here would also be maybe like a thyroid panel as well. The liver is the most likely organ where cancer would metastasize to or spread to. So I might be looking at a liver panel or comprehensive metabolic panel. And I may also think about maybe asking for these on a more regular basis. Probably if she's in co-care, these things are already being done, but I'd probably want to see the results of those. With chemotherapy and radiation, the chance of birth defects goes up. So if they are under chemo and radiation, they're probably already getting ultrasounds. But if they're not, would I ask for more ultrasounds, and would I require it at a more frequent basis? And then there's also the biophysical profile, you know, just checking the health of the placenta, the baby, fluid levels. And when would I start asking for that? Would I do that sooner in pregnancy, and would I want to do that more frequently? If let's just assume now everything is going well and the client goes into labor, I might consider taking vital signs more often, and also monitoring the fetal heart tones a little more often. And then I may also watch the labor pattern a little bit more closely. Melanoma is the most common cancer that would spread to the fetus. And for melanoma specifically, a placenta biopsy is indicated. So I'd want to make sure that I have a relationship with pathology, and if not, would I need to send that to the hospital? Do I have some kind of arrangement where I could, you know, take care of that? So that would be another consideration I would think about before taking a client into care. So let's just assume everything goes well, and then the neonatal signs just after birth, maybe they're abnormal or maybe slightly off. You know, what's the relationship with the receiving facility? Mariah might remember, I think it's actually quite a number of years ago, but there were a couple of high-profile cases in Virginia. One was for a death of a post-date, and then one was a breech, and there was a little bit of backlash. Yeah, Mariah, go ahead.
Oh, nothing. I'm remembering them both, so
Yeah.
it doesn't take
So
much.
there was yeah, it doesn't take much at all, exactly. So there was some public um, negative publicity, and it didn't reflect very well on midwives at that time. Uh, the other thing would be, are there any legal limitations or regulations to consider? Virginia is actually pretty liberal. We have a pretty broad scope. A lot of it is informed choice. Um, so again, when I'm asking, why it's a woman with cancer coming to a midwife for care, um, probably really want to talk about a lot of informed disclosure and making sure she understands what the, what are some of the risks that are associated with it. Are there other options? For example, in the area where I live in Virginia, CNMs now, they're much more common in the local hospitals than they used to be before. And if she's not able to have an out of hospital birth, can she still manage to do a natural birth in hospital? If there is co-care, and again, that is the standard of care, maybe perhaps being a doula for her um, in that situation. So that's pretty much all I have. My references here, but I really would love to hear from other people that have maybe had clients that have had cancer, or other experiences, maybe other things that you might think about if you do have a client that comes into care that presents with cancer. So yeah, I would just love to hear from other people. And I think Joya, you said you had a friend that had cancer that recently she passed away. You said, I think last week,
Yeah,
was it?
yeah. So my girlfriend, um, she was pregnant. We didn't know. Nobody knew she had cancer. She gave birth in October last year, and um, she had a hospital birth. Came home, and a couple days later, I think from the details that I was able to gather, that she went back to the hospital. She had had her intestines burst, but they didn't figure out that it was cancer for a little while. I feel like during pregnancy she was presenting like anemic, and that was a big part of it. But it was stomach cancer, and by that time it was stage 4, and she passed away about 2 months ago, 34 years old, and her baby was 6 months old. So it all happened pretty fast.
Lucky. Romy covered a lot of that at the very beginning. Um, so if you want, once we are done here, you can go back and watch the whole presentation. Or Romy, you can cover it in a little bit. I think there were a couple that got on late after I sent out the email. So. Hey, Romy, I actually have a question on, let's see, 3 slides back, I think it is. Okay, the treatment options one, that one. Okay, so where it says therapeutic abortion no longer promoted to start treatment, I find it interesting. It says that there's no data to suggest that the pregnancy termination alters the biological behavior of the tumor or the patient prognosis. So, but do they have any data on outcome? That's my question, Christina. So if they don't do a therapeutic abortion and they start treatment, what's the outcomes for the baby? I'm thinking informed choice for my clients. If we're talking about a therapeutic abortion versus not doing one, and the risks to baby, that's great that there's that it doesn't, a therapeutic abortion doesn't affect the mom or, the prognosis, but what about baby?
Right. Yeah. So I just moved back one slide, and
Mhm.
so yeah. So when a woman is deciding whether or not to take an allopathic treatment, I like this slide because it shows if you're going to take treatment during the first trimester, that's pretty much when all the nasty stuff can happen, because that's when the foundations for like organ, brain development, bone structure. That's when everything is occurring. And I think on a later slide, I'm not sure where. I think it's maybe 2 slides up, which show that for chemotherapy specifically, the increased risk to the fetus during the first trimester is close to 15% for
Okay.
birth defects.
I must have
So
missed the data.
yeah, and that dramatically decreases. I think on that slide it's like 1 to 2%. Yeah, it's 1.3% during the second and third trimester that those birth defects go down. Radiation is a
That
completely
helps me.
different.
I didn't hear the data when you went through it. So
Yeah, I think I kind of
5%
brushed
of
over it.
known
Yeah.
birth defects.
Yeah, radiation, there are so many other choices than radiation.
So,
Radiation
thanks,
is really
Romy.
the nasty one. Yeah. So that
Any
one,
other
if I,
questions that you guys usually, your questions have been great. Let's see. Yeah, did you mention this last question of Alaki's, the cancer spreading to the fetus? Did you find anything on that, like percentage wise, Romy?
yeah, there is, it's
We're
the
not hearing you. I
melanoma.
can see you talking and I can see your thing lit up, but I'm not hearing you.
Okay. Let me,
Nope. We were talking
I
about
can hear
technical
her. I can
difficulties.
hear
You guys
both of
can hear
you.
her. It's just me.
Yeah.
Hold on. Now try.
okay. Are
There.
you able?
Much better.
Okay. So the question about metastasizing to the fetus, it
Yeah.
is melanoma is the one that has the highest risk.
Got it.
That's the highest risk one. And interestingly, it's the male fetus is more likely to get it than the female. It's in one of the references I have. If you wanted to look at it, I don't have the exact number off the top of my head. But the one would be melanoma. That seems to be the one that crosses the placenta.
Wow. And it's not shocking that boys are more often affected than girls. That's just across the board for whatever. And when you're talking about fetal development and defects and things. Romy, can you see Rachel's question?
Yeah, let's see. I did not read anything in the studies about someone being diagnosed with cancer during pregnancy and then the cancer being cured from it. Like I said, I read a lot of anecdotal reports about people switching to raw diets, and I actually talked to one herbalist in Virginia, and she said she has a really high success rate with curing cancer, but nothing that pregnancy itself cures cancer. And really, a lot of the physiological changes that support pregnancy also support cancer development. Yeah, sure.
I actually had a friend who went on the HCG diet and she had a little tiny slow growing cancer that went out of control just from the hormone HCG. So that was back when it was legal. Yeah. So, and it would have taken like 20 years for it to actually develop. It was that, I forget the name of it, but it was that type of breast cancer, and it went out of control just from that one hormone. So.
Oh.
Mm-hmm. Any other questions for Romy? Thanks for a very thorough and interesting presentation. You've done great here. Andrea, I don't know. Romy, did you find any other ways to test fetus or baby other than placenta? They're just wondering if there's.
I did not read anything about testing the fetus. The only thing that came up, and it came up, I want to say, in at least 2 or 3 of the studies. I think I probably read almost 20 papers, and only the placenta biopsy is what came up. But I would have to think that there might be other ways to be able to test it, but I didn't come across anything in any of the papers.
You know, I think it would be hit or miss if
Like
you
maternal fetal medicine. Sorry, go ahead.
Yeah, I would think it would be hit or miss, especially if it was melanoma that had gone across. Even taking an amnio and amniotic fluid with sloughed off skin cells, it's gonna be hit or miss whether you even get that skin cell in that sample to
Right.
test for. So yeah.
And the scans, the ultrasounds were looking more at birth defects and and such. So that yeah, I think that would probably be a question for maternal fetal medicine. If you're doing co-care with them, is there a way for them to be able to test that? Also, some of the treatments can lead to childhood cancer as well. So it may not necessarily show up at birth, but there was a higher incident rate of childhood cancer as well with treatments like radiation and chemotherapy. So that's also something, obviously an oncologist would probably go over that with your client.
Wow. Okay. Any other questions? That one question that's on the board right now, what factors risk a client out of care? That's, yeah. If you're like Virginia and your regulations are pretty liberal and open-ended, that's going to be something serious to think about as a practicing midwife.
Yeah, and I think a lot of the things that show up that we would normally risk a client out of care are also the things that would risk someone with cancer out of care.
Yeah.
Like we would risk somebody out for IUGR, whether they have cancer or not, or if they have significantly anemic, we would risk someone out of care for that. So
exactly.
Yeah.
Any other questions? I think they're giving you some run for your money, Romy.
I have a quick comment. We did a birth for a family who the husband had been widowed and remarried, and his first wife died after the birth of their third child. They thought she had like fibroids or something in pregnancy. I'm not sure, but they noticed a growth and they thought it was fibroids. And then she just didn't stop bleeding postpartum. Her bleeding just never went away, like 4 to 6, 8 weeks, whatever. And they did some more scans and found out that she had some really crazy rare endometrial cancer. And at that moment, postpartum, they gave her 3 months to live. And I think she ended up living for like 3 years maybe, because they went totally like, whatever, alkaline water, raw foods. They did all the naturopathic stuff, and it kept her going for a while. But I had never heard of that type of uterine cancer, in some rare endometrial cancer that presented like a fibroid. And so I was like, oh yeah, super sad. But anyways, I just thought on the topic of cancers, she went through her whole pregnancy with it too, and didn't know that it was a cancer, but it was growing there in the uterus with the baby. Interesting.
Thanks, Christina. This is not the lightest of topics like some of our presentations, but so important for us to know about. Romy, do you see Anna's question?
Yeah.
Can
you hear me?
Yes.
Yeah, so it may not necessarily show up on a standard OB panel. Not getting too specific about a client that was going under diagnostic testing during her pregnancy for cancer. Her white blood count, there was some issues with that. And then she went to maternal fetal medicine to do some follow-up there. But I think it's a CA-125 they look at. And then for breast cancer, you know, the mammograms and the biopsies and things like that. So you may not necessarily see anything that shows up on a standard OB panel. But, you know, there might, again, I'd probably be looking at the CBC, you know, are they having issues with platelet counts, the anemia, and also the white blood count. I'm not sure if that answers your question or not, Anna. But it wouldn't be indicated if there was something off with that cancer may not be the underlying reason for it.
Thanks, Romy. Okay, I'm going to say this while she's on the references page. I want you guys to look at how beautiful her references are and how they're all latter years, not previous. Everything's current, and she's gone and looked at things. So I know that we've got some students who are coming in and wanting to do clinical rounds presentations and they're having a hard time finding the references. So if you're one that's going to be presenting this semester, this is model. Just take it as that. Rachel, usually when we do clinical rounds presentations, and you'll learn about this in evidence-informed practice, you can use seminal articles that can be like 100 years old. I think one of the seminal articles on delayed cord clamping is like 80 years old. Erasmus Darwin is the author of it. But besides the seminal articles that everyone is expected to cite as the foundation, they should be within the last, well, Courtney would say 3 years. I usually give it 5-ish. If you need to go back a little bit further because it's a topic that isn't referenced and isn't studied a lot, then you can go back a little bit further. But that's pretty much the guideline. Depends on the teacher. Courtney's 3 years. Usually I'm 5. So yeah. Cancer research is big. Yes, Christina. But how big, Romy, how many articles did you actually find specifically on pregnancy?
There's quite a lot. But most of them were focused on the treatments of cancer. It was very difficult to find the impact of cancer itself. The impact of cancer on the fetus, impact of cancer, or the pregnancy impact on cancer. It was very much focused on the treatments. It was only maybe 1 or 2 articles I found that kind of focused a little more. And those were the ones that were like the homeopathy, the King Saudi University, and the Benagerie treatments. So those were the ones that had a little different focus, more on the cancer, but those were not necessarily specific to all types of cancer and pregnancy.
Thank you for being willing to go out and find the ones that gave us a well-rounded picture of what pregnancy and cancer is like. Very much appreciate it.